So Nitin, over to you for high-dose aflibercept in macular diseases, reducing the burden of intravitreal injections. You have 7 minutes for you, sir.
Thank you, Prashant, and thank you for letting me be part of your session. Well, happy to start off on how do we advance these slides from the. Yeah, it'll work now. Arrow, right? Yeah, that's fine.
Next we take this. The third is
Good. So one of the main reasons why we get suboptimal outcomes in the treatment of macular degeneration or diabetic macular edema is undertreatment. The number of causes for undertreatment could be the financial burden, could be the burden on the carer, burden on the patient, and so on. And there are a number of strategies to try and get the injections at the right time, and not only at the right time, but also making sure that the patient is happy to keep accepting the treatment. And one of the philosophies is to increase the molar concentration of the drug that's injected. Now, everything starts from modeling, and PK modeling supports the concept of extended injection intervals if you increase the molar concentration of aflibercept. So, in this case, if the aflibercept concentration is increased fourfold, you can actually get 3 weeks more that the drug continues to act. And that's also borne out in animal studies, the chronic retinal vascular leak in the rabbit, showing that the drug, an increased concentration of the drug acts for longer. So what I'm going to talk about is the aflibercept 8 milligram dose, which is bundled into 0.07 rather than 0.05 mils of injection. The initial results from the Candela study, which sort of compared 2 milligrams and 8 milligrams given in a similar pattern, which is every 8 weeks, showed that the higher concentration of the 8 milligram concentration produced much earlier and more sustained reduction in the central retinal thickness, and the proportion of eyes without fluid in the macula, which is the green, was much more than the 2 milligram dose. And consequently, the visual gains were also much better at week 44. So here's a summary of what happened, and the side effects of a drug that we already know were no more with the 8 milligram than with the 2 milligrams. So then we go on to our experience in AMD and then in DME. The AMD one is the Pulsar study, where they compared, when I say 2, I'm also one of the investigators, but 2 milligrams of aflibercept versus given every 8 weeks, 8 milligrams every 12 weeks, and 8 milligrams every 16 weeks. A 1-to-1-to-1 randomization, and what we see is that's the dosing schedule. And because part of the thing is on a PRN model, not on a treat and extend model that we are used to, here are the criteria for shortening the interval in the first year and second year, and of course extension in year 2. So there were over 1,000 patients in this study. The BCVA outcomes were equal for all 3 arms. That is the 2 milligrams, 8 milligrams, 12 weeks, and 8 milligrams, 16 weeks. The central subfield thickness was also exactly the same. So what it means is that if one gives the drug at longer intervals, a higher concentration, you can achieve the same thing as you can, but with lesser number of injections. As you can see, the blue indicating 8.2 injections as compared to 12.8 with the standard Eylea. So that's also signed here. And in fact, more than half the patients could actually have gone on to more than 20 weeks. So if you think of it in your mind, that means 2 injections or maybe a little over 2 injections a year. That is a very comfortable level of dosing. This swimmer plot shows the same thing. And there were no new adverse events in this study. So no new safety signals, and this is a summary of what I've just been through. Coming on to diabetic macular edema, which is another totally different beast. The Photon trial, again, 3 arms, aflibercept 2 milligrams every 8 weeks with 5 loading doses, every 12 weeks and 16 weeks, but with 3 loading doses, a bit like what we do in macular degeneration. So it's slightly different from our standard practice. Again, looking at the criteria to decrease the interval or increase the intervals. The patient disposition is about the same in all groups, although the randomization is 1:2:1. Patient characteristics are the same, and about a third of patients had previous treatment with laser and other anti-VEGFs in the past. The primary endpoint, which is the BCVA or change at week 48, was equal in all groups. And at week 48, which is close to a year, all 8 milligram groups, more than 93% of them had a dosing interval of more than 12 weeks, so an injection every 3 months. At 96 weeks, which is the end of the study, 2 years, this relationship was maintained. And in fact, 90% of patients had injections more than 12 weeks, so every 3 months again. 47% of them could have gone on even further. And that's the swim lane graph, which shows you that, the results of what I've just explained. The central retinal thickness, the thing to note here is the blue line. As you can see, that's the 16-week dosing. And you can see there's a lot of fluctuation in the fluid. But ultimately, it comes down to...
Time is over, and you need to wind up.
Thank you. And so with time, it all settles down. No new safety signals, and that is the outcome. So thank you, but it just shows that we can actually use higher concentration to get equivalent results in both diseases. Thank you. Whoa.
Thank you so much. It was wonderful. Just a question before you leave us. Do you have some guidelines, like which patient? Do you customize your treatment or you follow the protocols?
Well, I think as we're all moving on, we are doing more and more of treat and extend rather than following the standard formula, because no two eyes are the same. The response is not the same. In AMD and DME, again, based on many other factors, if you get good response early, you can already start your extension earlier. You don't have to do 5 doses or 3 doses. That's the way I follow
that's what is happening. The new drugs are coming in. We are just head-to-head studies. We do not have comparative trials. So we do have to customize depending on your patient requirements.
Yes.
Is that the right way?
Yes. And I think with AI and all that coming in, it makes it easier.
Thank you. That's the next thing.